Hello, I am Amy McDevitt, Assistant Professor at the University of Colorado Physical Therapy Program in Aurora, Colorado. And I'm going to be presenting on the results of a qualitative study looking at the clinical reasoning assessment tool and faculty perceptions of development and assessment of clinical reasoning in physical therapist learners. I am presenting on behalf of my research team, which includes Mary Jane Rapport, Jenny Rodriguez, and Matthew Miller. So we would like to thank ELC for accepting this poster presentation, and we hope you find the results and the information informative. And please connect with us by linking on my name in the virtual booth in order to connect up and get more information. So the title of our study is Use of the Clinical Reasoning Assessment Tool to Inform DPT Student Assessment, a Qualitative Study. So to give you a little bit of background, clinical reasoning is a multifaceted skill set, and it's crucial to optimal patient care. And what we know is that there is inconsistency in the use of language to describe the clinical reasoning process really across many entry-level doctor of physical therapy curricula and programs. The other thing that we do know, based on the research, is that the ability to assess the development of clinical reasoning skills is very challenging, and it's really due to the complexity and the abstract nature of the skill. The clinical reasoning assessment tool was developed to assess students' progress in the development of clinical reasoning really along a continuum. And this really was developed out of Creighton University at around 2015. And so that tool is really going to serve as a foundation for this study. The CRAT has been studied, and one study did describe how the CRAT showed student progress across 4 different time points in didactic and clinical components of a DPT curriculum. So the purpose of this study is really to just explore how academic and clinical faculty in a physical therapist curriculum used the clinical reasoning assessment tool to support the development and assessment of clinical reasoning in physical therapist student learners. So the methods for this particular study included 13 participants which were recruited from within the CU physical therapy program. We had 8 core faculty, 3 affiliate, and 5 clinical instructors. All of these individuals had to have experience using the CRAT and had to have been teaching our learners within 6 months. So we had 3 focus groups, which were audio recorded until saturation was reached. We created a focus group interview guide that really incorporated language trying to get at perceptions surrounding the use of the clinical reasoning assessment tool with student learners. And this is really both for teaching, learning, and assessment. So before I go further into data collection and analysis, let's take a look at the clinical reasoning assessment tool in a little bit more detail. So the clinical reasoning assessment tool is comprised of 3 domains. So those domains include content knowledge, procedural knowledge, and conceptual reasoning. Basically, within these 3 domains, we have what are called sample behaviors, and then we also have a visual analog scale, which goes from beginner to proficient to really help faculty and students kind of understand this continuum of clinical reasoning. In the area of content knowledge is going to include foundational knowledge and concepts related to the International Classification of Functioning Disability and Health, or the ICF framework. But content knowledge also is knowledge surrounding health condition, anatomy, basic sciences, histology, kinesiology, that sort of thing. So it's really more or less identification of facts. Procedural knowledge is a little bit different in that it includes psychomotor skill. This psychomotor skill may include choosing appropriate tests and measures, but it also includes intervention, safety, and then also communication strategies, including verbal and nonverbal communication. Then we have conceptual reasoning. Conceptual reasoning is really that cognitive and metacognitive skill set. So this is analyzing the data, or really that milieu of information that is coming in from the patient encounter. It also includes a component of self-awareness and reflection, and it's really a synthesis of all of this information that's necessary in order to make judgments and clinical decisions. So it's appropriately justifying decisions, modifying and being adaptable, and also interpreting examination findings. So it's really taking that content knowledge, that procedural knowledge, and really pulling it together in the context of a patient. So for content knowledge, we're looking at evidence of content knowledge that's either limited, moderate, strong, or comprehensive. In the area of procedural knowledge, we're looking at accuracy using that same scale. And then in the conceptual reasoning domain, are the students able to make and justify choices for a few things, or most things, or all things? And so that's kind of what this tool more or less looks like. And so when we go back to our methods, we actually did introduce the tool again to all of the participants to refamiliarize them with the tool and help to kind of jog their memory as far as how they were using it. So as far as our data analysis, we verbatim had transcripts that were analyzed using a team-based approach. It engaged all of the co-authors and included multiple debriefs in order to really become more solid in our convention for approaching the codes and the themes. And we used a framework analysis to identify some of these emergent themes. As far as data collection, another component of that was gathering information on participant demographics. So we wanted to know amongst the participants, what was their highest earned degree? Were there ABPTS certified specialists? What was their role in the PT program? Were they core, affiliate, or clinical instructors? And then if they were teaching in the curriculum as core or affiliate faculty, were they more involved with coursework that included the beginner learner or the intermediate? The beginner learner was considered those individuals that are in their first year, and that was a lot of the foundational sciences and skills-based courses, as opposed to the intermediate learner who was in more of our track or specific courses, neurology, orthopedics, medical conditions, as well as some of the advanced coursework. We also gathered information about number of years contributing to the PT program, years of clinical practice, and then what clinical setting. So when we looked at the results, there were a couple themes that emerged. One thing that was interesting is that all the participants did similarly define clinical reasoning. And so here we can see clinical reasoning is what the students learn from the subjective history, the exam, and condensing it down into something clear and solid while integrating didactic knowledge and the hands-on skills relevant to the patient in front of them. So that was a finding that came really in the beginning when we were trying to qualitatively gather information just about different perceptions on the word clinical reasoning and what it means in education. As far as some of the themes that were extracted from the data, the first theme was organization and structure. And so what this meant was that the clinical reasoning assessment tool fostered understanding of clinical reasoning through organization and structure. So if we look at some specific quotes from the participants, the CRAT provided structure for beginner and intermediate learners, preparing students for a patient simulation-based or clinical encounter. The CRAT may have helped by providing students with a different way of looking at their own clinical reasoning development. And then finally, the CRAT in its organization takes you through a patient encounter. The content knowledge is the chart review, the procedural knowledge is carrying it out, and the conceptual reasoning is on-the-fly modification based on what you're hearing and seeing during a patient encounter. And that quote came from a clinical faculty in an acute care surgical ICU setting, describing what it was like to work with a student. And so overall, the participants did describe that the clinical reasoning tool in itself really offered a way to organize dialogue, a way to organize an encounter, and it really gave structure to not just the patient encounter, but to some of the language that we use to describe clinical reasoning. The second theme here is dialogue and self-reflection. So the CRAT facilitated clinical reasoning through dialogue and self-reflection, including the ability to articulate a rationale or a justification for decision-making. So if we look at more of the specific quotes and results that came from that theme, the first is, I just flat out say, if you were to consider the knowledge about the situation, how you used your hands, or what you were thinking about your decisions, Which did you feel strongest in, and which was the hardest? When an instructor asks guiding the instructor gets a different window into the thought process of what the learner was thinking while they were doing it. The CRAT tool helped the student to, quote, frame their own thoughts from a reflective standpoint, end quote. And I found the CRAT helpful to guide reflection. I rate them and they rate themselves, and we see how close we were. It was helpful to see what the student noticed. So really, the tool in some of its sample behaviors and descriptors in each of those 3 domains offered participants the ability to have a framework to their dialogue, but then it just offered ideas and thoughts on how to really drive self-reflection in the student. And the third theme that we found with the CRAT was assessment of clinical reasoning in the learner through benchmarking or scoring students on the CRAT based on the continuum of beginner to proficient. So as far as some of the results there from that particular theme of benchmarking, a participant stated that they observed the students' overall performance and scored them based on their consistency at a level on that continuum. So that was one convention. A different participant, quote, I considered entry level to be competent and used that as the starting point, end of quote. Another participant thought that the first 2 domains really drove the third domain. So content knowledge and procedural knowledge, the student can potentially be good at both of those, but then may not do well in the conceptual reasoning or vice versa. So they were seeing this relationship between the 3 domains of the clinical reasoning assessment tool. So if we look at some of our grounds for discussion, after we really distilled down the results, what we found is, again, clinical reasoning is complex, and the contextual nature of clinical reasoning is known to be difficult to define, teach, develop, and assess. But we believe that the CRAT was developed to really fill a void in clinical reasoning assessment tools. Faculty used the CRAT to support the development and assessment of clinical reasoning within 3 main themes: fostering understanding of clinical reasoning through organization and structure, facilitating clinical reasoning through dialogue and self-reflection, and then finally assessing clinical reasoning in students along the continuum of learning through the use of benchmarking. So in conclusion, clinical reasoning is a very crucial and critical skill set for physical therapists, and there is limited guidance to support the teaching and assessment of clinical reasoning. The CRAT may serve as a useful tool for faculty to improve the development and assessment of clinical reasoning in physical therapist student learners. And it seemed to offer structure and organization to the clinical reasoning process, which may have helped foster student reflection, dialogue, and really allowed for some benchmarking of the learner. The CRAT may support faculty in their work to further the learner's understanding of clinical reasoning and provide some objectivity to assessment using benchmark in the domains of learning within entry-level physical therapist education programs. And so what we know from learning sciences and learning theory is that it is really important to start looking at this continuum and to look at situated learning, which is really how we can use this tool both in the didactic realm and in clinical education. So we believe that this tool might be a really effective way to start looking at the learner's development of clinical reasoning along a continuum, and will hopefully further inform really our development and our progress in this area of studying clinical reasoning in physical therapist education. These are the references for the many individuals who have contributed in many ways to the clinical reasoning assessment tool and a lot of the literature surrounding clinical reasoning. We would like to thank, as a research team, the Academy of Medical Educators and the Reimer Grant for funding this research and allowing us to look at clinical reasoning and the clinical reasoning assessment tool in more depth. So thank you to our grant sponsor, and thank you to all of you for your time and attention.